Thank you very much for inviting me and my first visit to Exeter, and I really enjoy my visit so far. And I was asked to give this presentation about special considerations for older patient with heart failure. And as you already seen this morning, all this data have been presented to you. This is almost 2 decades old data. For the new cases of patients with heart failure or established cases, they are clearly, essentially, a disease of older people. And more recent data, again, we have seen these slides before, and we can see the mean age of patients going to hospital with acute heart failure are kind of 78, and median age of about 80. So effectively, it is a disease of very older people. And you hear all these, 10% people die during the inpatient, and that's average. For people in the 80s, would be about 15% or more. And even for a year, 1/3 of the patient will pass away. And again, this has been shown, so I don't need to spend much time. The age itself is the strongest predictor of worse mortality. A lot of optimism this morning about managing heart failure. Indeed, I think the heart failure specialists should be congratulated for 3 decades of research and medication and device therapy. And we have really given many of our heart failure patients 1, 2, 3, perhaps decades of quality of life. But eventually, we simply shift the curve to the right, and we are eventually dealing with a disease which has a very adverse outcome. So, since the heart failure in older people are the major subgroup of patients in heart failure, and why do we need to talk about heart failure in older people? I think the main reason is perhaps that we haven't talked about too much about it, and a lot of talk, rightly so, about heart failure are focused more perhaps in younger individuals. As we can see, older people in clinical trials are very much underrepresented even now. So these are a few points I would like to focus on. As I was asked to prepare for this presentation, and I simply look back to my practice for the last 6 months or a year, and share with you some of my experience. As we talk about acute heart failure, we talk about elderly, and therefore there are not much evidence, I'm afraid. So very much my personal touch or personal experience, I hope it may be helpful. But nevertheless, these are some of the specific features about heart failure in older patients. They have a slightly unique heart pathophysiology, significant co-morbidities, and hence polypharmacies. They already heard so often now, they are really functionally not too good. Increasingly, the geriatrician have this interest in assessing frailty, which I perhaps say 1 or 2 words about it later. Aging heart and is a talk on its own, and not expert in this field. Debate go on whether this is a normal aging process or a disease process. Nevertheless, the consequences is they are increasing myocardial cartilage and also development of fibrosis and the abnormal calcium metabolism, and the stiffening or the peripheral vasculature. And this mechanism will accumulate the development of what we often hear about the heart failure with preserved ejection fraction. This one feature. Other feature is also, of course, is comorbidities. And again, when we talk about comorbidities, we often focus on cardiac comorbidities. And let's look also outside the cardiac comorbidities, which involving other organs. And there has been increasing interest of managing comorbidities in the recent guideline been quoted many times, the ESC guideline 2016 clearly have a big sessions on comorbidity and stating it might interfere the diagnostic process, aggravate heart failure symptoms, and contribute to a significant burden of hospitalization and mortality. And also, even likewise, the British Society of Heart Failure last year had a big sessions on comorbidities, emphasizing actually majority hospitalization in the year before death are not necessarily heart failure related, but comorbidities related. And as I alluded to you before, and when we look at comorbidity, look outside cardiac, certainly kidney, lung, mental health, and skeletal problem leading to a complex syndrome of what we often refer as postural instability and falls. And this also, the chronic disease management often described as chronic disease pyramid. And the one we really talk about, the heart failure in older people, belong to the top group, the tip of the pyramid. And these are the people who have significant comorbidities, significant disability, and also very advanced symptoms. And again, you don't need me to remind you, and these people are taking a lot of medications, apart from cardiac medications. And in at least one study, observation study, to show 35% of older patients, average age of 75, have this score of less than 16. I mean, they are functionally very dependent. If these people are living in community, they're very likely they will require a package care. And frailty is increasingly a concept, more than a concept, as clinical syndrome that geriatrician would have an interest. We don't have a definitive definition yet, but effectively it's a syndrome characterized by a decreased multi-organ physiological reserve. And consequently, there will be diminished resistance to stressor and leading to a risk of adverse outcome. Earlier we talked about the difficulty of assessing prognosis. And likewise, that is another area that perhaps you should be able to look at the frailty, not only to risk stratify, but also to assess individual needs, as been mentioned, and also assess the potential reversibility of frailty or disability. Quickly, all the tools that we've been using, that we heard about, they often focus on comorbidity or disability. And frailty is more than that. And this is another slide, complex. Effectively, if you assess it properly, and that will predict patients who are more likely to have adverse outcome, including hospitalization, falls, and procedure complication, and so on and so forth. So why we talk about heart failure in older people? These are some of the unique features in our older patients. In practice, what does it mean? I think it really means I have interest, I still do general medical intake, I'm in the front line, and I have interest in heart failure, and to be honest, I still have difficulty in some cases in diagnosing heart failure, more so with older people. And we really need all the help we need. And so the first question is a heart failure, and then already alluded to you, comorbidities can interfere the diagnostic process. And we're all familiar with all these are very common in older people. And these are from ESC, and you can see even in a typical patient, the symptoms can be, some of the symptoms are very sensitive, but they're not specific. And some of the specific signs are not very sensitive. There's always that kind of trade-in. But in older people, perhaps more so, they're presenting with even less typical kind of features, which we heard so much about. And the breathlessness, we already mentioned, that neither sensitive nor specific in the older people. And I often have to see patients in stroke units because they inevitably do echo on many stroke patients, and they find that they have poor LV systolic function. They simply don't move enough, and like many other older people, to have the symptoms of breathlessness. And again, already alluded to you, but a kind of orthopnea or paroxysmal nocturnal dyspnea, perhaps maybe more specific. Delirium, confusion, challenging syndrome, and sometimes their presentation will be just delirium. And perhaps we are better, relatively speaking, in detecting hyperactive, really confusing patients, and many of them have hyperactive delirium, and that's even more challenging. And cognitive impairment clearly will make diagnosis very difficult. So we still have to do our utter best in the history and examination to diagnose them, but we have to acknowledge the limitation of just clinical assessment. X-ray, up to 20% apparently to have normal chest X-ray and acute heart failure. But again, older people, X-ray are important to exclude other pulmonary pathology. Obviously, when they have pulmonary edema and pro-effusion, that would be easy. ECG and ability to recognize that normal ECG is very, very important because they have such a high negative predictive value. And then you quickly go through other tools, peptide. Most of the peptide study, BNP study, is to help diagnose in community. A study in acute setting is very, very limited, and the use of peptide to diagnosis in acute setting in older people, even evidence are even more scarce. So we heard all this, and if you look at the list of possibility of elevated BNP as an advancing age, these are all the patients I see, which make it extremely difficult to know. And in where I practice, we don't actually have BNP in the front door. So difficult to know how useful it is, and I would like to have it, at least to have some experience. As I alluded to you, diagnosis is so challenging, anything would help. Ultimately would be echo, and this is, if it's heart failure, what's the etiology? You, again, familiar, this heart failure syndrome is not a single disease entity. And you talk, you're not meant to read it, but to reflect to you the capacity, the etiology. Firstly, the heart muscle disease, and increasingly with the valve disease and arrhythmia, and many others. And this is National Heart Failure Audit, and as we see in older people, LV systolic dysfunction as a cause of heart failure is still the majority, but there are more valvular disease. And what it doesn't capture in our UK National Heart Failure Audit is the heart failure with so-called normal or preserved LV systolic function. I just quickly reflect some of the cases I've seen last year. If, unfortunately, I don't think sorry. And if I were asked to see a patient like that, and in some ways a little bit very poor LV systolic function, and it's relatively straightforward. But increasingly, you know that we have an epidemic of valvular disease. When showing off my age now, when I was a medical student, the common cause of valvular disease would be rheumatic valve disease. And obviously now it's all age-related valve disease. And aortic stenosis, and as you can see, and my apology, this slide will not like that early on. And when you have someone with a, by and large, we diagnose it reasonably well. You have a normal LV systolic function, you generate a peak velocity more than 4 beats per second. That's quite straightforward. In most cases, can be quite straightforward. In other cases, but remember, there are many potential pitfalls in estimate the valve area, and there will be challenging cases, and we need imaging experts when you have inconsistent data and some of the more complex syndrome, low flow, low gradient kind of severe stenosis. And the other one is mitral regurgitation, and again, perhaps in this case is fairly obvious, and reflecting on a case I saw, and these elderly people with lung disease, maybe high BMI, and I saw the patient, clearly to me, it was a valvular disease, the echo come back as mild MR. And so clinical feature does come in if you really convinced this is not, and you have to ask someone else to do to look at the valve more clearly, and which turned out to be more significant disease. And I see quite a lot of right heart problem, and if it's and this is a topic on its own, extremely challenging in older people to know what they are, and so in many cases would be lung disease. Increasingly, I see many obesity-related hyperventilation syndrome, and so many of these patients might end up needing a CTPA and lung investigation to find out this complex syndrome. And quickly, this is a patient with amyloid. They are usually senile amyloid, unlike the other form which have more poor prognostic outlook. And again, quickly, for many of my patients have CABG many years ago, and you just have to be aware that a couple of cases who have constrictive cardiomyopathy, and just beware so-called heart failure, right heart with apparently normal LV systolic function, and they have expanding symptoms. Just be aware of the complex etiology, and of course you can truly have some heart failure with normal ejection fraction. And a topic on its own, and complex, and effectively in normal compliant LV, the blood is usually sucked into the left ventricle in relaxation phases. In diastolic dysfunction, it's so high pressure, so stiff, and somehow we need to push the blood into the left ventricle in the filling phase, leading to very high LV and also LA pressure. And complex echocardiographic investigation. But for those who are not imaging specialists, and this would be helpful kind of clues, LA size, unexplained enlarged LA size. E to E pi more than 15 usually quite helpful, and maybe unexplained LV thickness as well. So very challenging, older people with heart failure syndrome because of complex etiology. And also triggers, and again, this has all been presented. I don't want to go through, don't need to go in detail, but this is more commonly we see in older people: infection, exacerbation, COPD, anemic, medication. These are more cases I see in older people coming with decompensation. And they tend to come in with relatively less kind of rapid deterioration rather than the first group. Treatable cause is important, as I alluded to you. Not so diagnosis, etiology, think about the treatable reversible causes. And the initial treatment, I'm sure we may be covering elsewhere at the talk, hasn't really changed that much for the last 2 or 3 decades. The loops, still very much IV loop diuretic. Selected patient may need IV vasodilator. And what's important is, as have been mentioned, some of the many other more invasive or intervention, which I would group them as a bridging intervention. Bridging for decision, you don't know what's going on. Bridging for decision, bridging for diagnosis, bridging for destination, and for some of this condition which has been mentioned. And I think that's where the geriatrician might come into the frailty assessment together with the cardiologist to really to identify the patient whether they will need this kind of bridging intervention. So I think it is important that the fact that they're old doesn't mean they shouldn't have this advanced intervention. On the other hand, the fact that we can do it doesn't necessarily mean we should do it. A lot of kind of interaction together. I think out of these, perhaps I would like to highlight the ACS, unless there are very, very good reason not to. And I think older people ACS, in majority cases, I will quickly involve my intervention cardiologist early, and some of them may end up to have some bridging intervention because many of my coronary intervention may be very helpful. A few practical points, no evidence base, and for really diuretic resistant, we tend to use another thiazide. We tend to use metolazone, 2.5 once a week to begin with. Increasingly, not increasingly, in very severe cases, they're working in different part of the kidney tubule. We have used acetazolamide as a combination, where of no evidence suggests to work. There are selected cases they work quite well, particularly right heart. And forget not, please do not stop the beta block. And again, hasn't been mentioned. This trial rarely mentioned because the patient recruitments are very unique. These two trials only recruit women, and the last trial only recruit American with African descent. And nevertheless, because of the patient we see in older people who significantly have hypertension, heart failure, and CKD, we do use quite a lot of hydralazine, mainly for blood pressure control. And that's another practical point I'd like to mention. So this is aftercare. You don't need me to repeat it. If you take evidence-based 3 neurohormone blockers, they do well, including older people. So a lot of aftercare. Comorbidity, iron, couple of studies confirm HF. So I do feel that they do give some symptom benefit in older people. A little bit benefit mean a lot to them functionally. And so based on the current criteria, the iron deficiencies are the absolute or functional. It's not 20 ml per minute. So, and cognitive impairment, depending which study you look at, 20-40% will have some degree of cognitive, and how to define them. Clearly, they will impair some of the assessment and diagnosis. Depression, with treated, would be quite rewarding to treat. Delirium, I mentioned before. Kidney, complex, really, really complex. But also remember, it is the older people, the people who develop AKI are the people who have CKD. And often we think AKI, acute kidney injury, as something reversible. It is not necessary, particularly our patient with chronic heart failure and chronic kidney disease. After the episode, they might have a permanent element of acute heart failure. Okay, lung disease and gout and all these are important. Pharmacy of, look at BMF and to look at so many medications you might be selectively, they accompany discharge. Perhaps I'd like to close by multidisciplinary. Why do I looking after heart failure patient? Ultimately, it's for patient care. This is important to have patient have on the right medication, which I don't need to repeat. There are a lot of diagnostic challenges, complex comorbidity, frailty, and so on and so forth. And yet, in reality, still less than 50% of patients with heart failure go to hospital are looking after by cardiologists. And this is 5 years later. And despite all the hype, despite all the effort, might be the NHS, maybe one reason or the other, a lot of patients are under general medicine or elderly care. And we already said when they're old, they're less likely to be under the care of cardiologists. If you're old, you're less likely to have investigation, which I alluded to you how important these investigations are. And if you're old, you're less likely to take. These are observational data. They might, not meant to be a criticism. But nevertheless, they are less likely to take evidence-based disease-modifying medications. Challenging. So I would conclude by saying there are many unmet needs for looking after heart failure with older people. And like what my previous speakers alluded to, and that should be a truly multidisciplinary approach, as suggested by the British Society for Heart Failure. And locally, we are quite proud of our multidisciplinary working. We sit down every single. I don't want my patient disadvantage that they have to wait for another waiting list for the cardiology input. And most of the investigation and intervention, including CRT, ICD, will be discussed in our weekly meeting, and they don't need to go on another waiting list. And likewise, many of these older patients require geriatric specialty input. They will come to us, but we also have a palliative care consultant to be in our team. And we use a day hospital, many advantages for helping older people with complex needs. I would like to say a lot of challenges, a lot of unmet needs. We need truly collaborative, truly multidisciplinary working. Thank you.